Good morning, I'm Philippe Gentil. I work at Innovision Women's Ultrasound in Nashville, Tennessee, and I'm going to make a presentation this morning about skeletal dysplasia. Good morning. So we're going to talk about skeletal dysplasia, and this is an extraordinarily broad topic, and the skeletal dysplasia have been divided into a number of disorders, and I have listed here four of the first classes. But before we can attempt to do this, I think it's important to be able to recognize what are the different findings. And so in this presentation, we'll just concentrate on the findings. That little introduction just to show you that skeleton has been very interesting for many people, and this music was actually from Camille Saint-Saëns. It was the Carnival des Animaux. So let's look at the different findings, and we're going to divide these into three large groups. First, we'll look at the cranial finding, and that will include brachycephaly, craniosynostosis, hypo and hyperteloris, Micrognathia, and some of the facial anomalies. Then we'll move into the axial skeleton finding, and we'll talk about the ribs, the chest perimeter, platyspondyle, the abnormal vertebrae, and so on and so forth. And then we'll finish by the appendicular skeleton, and then we'll talk about the different disorders of the limbs themselves. So let's start with the cranial findings. And you know that one of our good friends, Gianluigi Pilu, who has those clearly marked down slanting supraorbital ridges, so I made my skeleton to look like Gianluigi. One of the first things to look at is bone hypomineralization. This is a criteria that, if it is visible with ultrasound, is quite likely, otherwise it is unreliable. Here, for instance, you have a skull with no evidence of the skull table themselves. Now, this is unreliable because sometimes you may have the appearance of a skull, although on X-ray it would not be present. That is because ultrasound use reflection while X-ray use absorption. But if you find bone hypomineralization like this, think about three disorders: achondrogenesis, osteogenesis imperfecta, and hypophosphatasia. So a very simple list of differential diagnoses. Another thing to look at is the shape of the head. The shape of the head is measured by the cephalic index, which is the ratio of the biparietal diameter over the occipital diameter. If the head is too round, we talk about brachycephaly, while if it's too elongate, we talk about dolichocephaly. Now, brachycephaly is an indicator of trisomy 21 in the newborn and the child. It is not a reliable indicator in fetuses. However, when you see a baby's head that is too round like these, this is a normal one for comparison, when you see a head that is too round, look at it as a criteria or a soft marker for trisomy 21. There are other conditions that have brachycephaly: the Antley-Bixler syndrome, partial trisomy 9, the ring chromosome 11, and of course Cornelia-de Lange syndrome. Microcephaly is a condition in which the neurocranium is too small compared to the visceral cranium. And in the old days, this was a very tedious and complicated technique to do that, and the criteria that had been suggested were a biparietal less than the first centile, and you see the biparietal here is affected, but is not quite as much affected as the cranial vault, head perimeter over femur length, and so on and so forth. But they were very poor 2D criteria. One of my former fellow, Dr. Julian Leite, has made a much better approach to that. Using 3D reconstruction, she just measured the size of the brain using the vocal technique, and this is how to do this. You essentially put the gate around the object that you want to measure, as you see over here, and then start tracing the inside of the object that you want to measure. Here we're tracing the skull, As you can see, the tracing does not have to be very precise. It can be corrected later on. And you go from one slide to the next slide and correct the area in which the tracing has not been anticipated properly by the machine. Now that appears like a very tedious thing to do, but once you have done a couple of them, this is not such a hardship to do, and further it provides a much nicer assessment of the brain volume than simply guesstimate from the two-dimensional structure. And here you see the volume of the brain has been calculated, and you can correct the different slides to make them a bit more precise and get a better idea of what the brain should be. Once you have that, you can put the measurement in a table. You can put them in a table, and that table gives a nomogram with the size of the brain. This is a newborn that has a microcephaly, and you see it also has clipper face syndrome. It has some visual problem. This is a fairly severe anomaly, but difficult to recognize prenatally. Dolichocephaly is just the opposite. Dolichocephaly is a condition in which the head is squished side to side, and that occurs in a few conditions such as premature rupture of the membrane, growth restriction, oligohydramnios, or the acromesomelic dysplasia. Those babies have a head that is too elongated, as you can see on the scan here. Now there's a condition that looks like dolichocephaly, but is a different condition. It's called scaphocephaly. Now the head is elongated. Scapho is boat, elongated like a little boat. And this is not due to simply compression, but this is due to craniosynostosis of the sagittal suture. And that brings to the topic of craniosynostosis. Craniosynostosis are premature fusion of the skulls, resulting in a lack of extensibility of the skull at the level of the suture or the fontanelle. Remember that a suture is the space between two bones, while a fontanelle is the space between three or more bones. Now, if bridges occur between some of those bones, the development of the brain will induce the development of a skull that is deformed, and the skull will not have the normal shape. And this is an example here where you see the bridging that has caused a deformity of the skull. This is the cloverleaf shaped skull. Now I'm going to show you a bunch of tables, and those tables have been assessed in the following way. First, I use the keyword here, craniosynostosis, in OMIM, and I got 90 syndromes without age limit. And then to create a limit, I add neonatal, because of course you can get craniosynostosis that are not present in neonates. And then I use the same keyword, craniosynostosis, and prenatal ultrasound, to find how many articles had been published in that. So here we have the list of all the OMIM list, and here we have the number of hits in Medline. And that tells you which are the common ones to look for. Of course, Thoracic dysplasia here is one of the top ones, but the short rib polydactyly syndrome and the acrocephaly polysyndactyly are right behind. This is a baby that has Carpenter syndrome. You see that the ratio of the biparietal diameter over the occipital diameter is almost 1, and not only that, the space between the eye is widely separate, so this baby has hypertelorism. This is a baby that has Thoracic dysplasia type 2. This is the one with the cloverleaf shape, and you can see that the shape of the head here is far from the normal shape we tend to think when we look at the skull. And here is the 3D rendering, in which you can see the very abnormal shape of this baby. As you can see, there's a big gap here. That gap is not an artifact. This is the metopic suture that has been stretched so thin that there's essentially no bone at this level. Another thing to look at is frontal busting or bulging of the forehead. If you trace a line that intersect the front of the face here, that line should not cross the forehead. If the forehead is in that image, then we talk about frontal busting. And this is a normal fetus here. This is a fetus with Thoracic dysplasia. And there are several other conditions that present with frontal busting, and they're listed over here. Now, a condition that might appear as frontal busting is a midface hypoplasia. Here, the problem is not that the forehead is too big, it is that the midface is too small. And because of that, when you trace this line that we were just talking about a second ago, then the forehead seems to be bulging in front. There is a way to recognize this, and we'll see this in just a second. But here are some of the syndromes. Binder syndrome in particular is associated with midface hypoplasia. When you scan the fetus at the level of the eye, you see the image here with the two eyes at the same level, and the root of the nose here, the place where the nasal bone is behind that line that joins the two eyes. This is the same thing that you would see if there was no nasal bone, but as you can see, this baby has a nasal bone. So the criteria here for midface hypoplasia is that the eyes are at the same level as the nasal bone, and the nasal bone is not absent. We'll see absence of the nasal bone in just a few slides. The opposite of a bulging forehead, of course, is a slanting forehead, and this is the appearance with the drawing and with the ultrasound image. This is a case of Scephocephaly, and we discussed Scephocephaly a few slides ago. And there's much fewer cases of slanting forehead. Of course, if you have a slanting forehead, it means that the frontal lobes are hypoplastic, and so you're talking about lesions of the brain. Zellweger or New-Laxova syndrome, for instance, are forms of lissencephaly or problem of the brain. Another anomaly you can look at the bones in the skull is Wormian bones. They're not called Wormian bones because they look like worms, but because they were described by Olaus Worm, a Danish anatomist who wrote a letter to Thomas Bartolomeo all the way in 1643. So this is certainly not a very recent discovery. And this was the Latin letter. For those of you who are not fluent in Latin, I have here an English translation of this letter. And what he described are little bones that are located in between the sutures or the fontanelles, here in the anterior fontanelle. And the way to find these is to take a plane that is posterior and tangential to the skull. Here we see it going in the posterior fontanelle. Here we see it go into the anterior fontanelle. And when you look at those planes, then you can find those little bones in the suture. Here they are, and this is what they look like. Now this is visible in 2D, but of course if you have 3D rendering with reconstruction, then of course you can see them much easier. And this is the appearance here of those two little bones with the posterior fontanelle and the occipital table over here. Now, why would one look at Wormian bones? Well, they're associated with quite a few congenital anomalies. There are also some reported about this being associated with trisomy 21, although I've not been able to identify the original paper in which this was reported. But several of these skeletal dysplasia have Wormian bones. A low nasal bridge is a condition in which the normal nasal bone is hypoplastic or completely absent. Now, this is something that has been known for a long time, and I used to measure this many years ago by doing a coronal section of the face, as you can see over here. And in this coronal section, the criteria was that there was no bone in between the eyes at this level, and so there was a continuous dark echo on ultrasound between the two eyes. This is a baby trisomy 21, this is one with thyroid dysplasia, and their respective ultrasound. Now, of course, since the paper by Cicero from the group of Kipros Nicolaides was published a couple of years ago, everyone has, of course, switched to a sagittal section, which is much easier to obtain. And in the sagittal section, you can see clearly the difference between the normal bone that is over here or the hypoplastic bone, for instance, in this case of trisomy 21. And so that is currently the standard of how to do those measurements. Now, if you look at low nasal bridge, this is another way to say absent nasal bone. This is what the dysmorphologists use. You can see a lot of syndromes, 140 syndrome without age limit, and 39s that are present in the neonate. And in this list, trisomy 21 is not even listed. The reason for that, as you remember, is that OMIM does not deal with chromosomal anomaly. But of course, trisomy 21 and several of the other aneuploidies have low nasal bridge. Micrognathia is a condition in which the mandible is too small and project backwards, and it is not always an easy finding to recognize. Here we have two babies that have a normal mandible, and here we have two that have a micrognathia. The one on the right side is really easy to recognize. Below the lower lip, you're completely missing the mandible. And this one here is a bit more subtle, but this baby has trisomy 18. This is another condition in which having 3D is very useful, because if you do the multiplanar reconstruction, you can set the baby in the slides such that you have a perfectly midline sagittal section, and then you can do the reconstruction and see the presence of the mandible and its size compared to the rest of the face. Micrognathia occurs in a large number of syndromes, 233 syndromes without age limit, 27 prenatal diagnoses, and this is a list of the conditions that are associated with micrognathia. Let's move on to the axial skeleton, and here in the axial skeleton we're going to talk about the rib cage, the spine, and then the pelvic and shoulder girdles. And let's start with a bone that is quite interesting. It is the clavicle. The clavicle, as you know, looks like a long bone, but it is not a long bone at all. This is a bone that has an intramembranous ossification and not endochondral ossification. You know that all the bones that we have that derive from the shark being the fish that has a cartilage skeleton and not a bony skeleton. It is a primitive fish before the bony fish. All the bones that we have derived one way or another from those cartilaginous bone. So when evolution needed new bones that did not exist in the shark, and one of them, of course, is the skull, because the shark had a very tiny brain. When the evolution needed to have a larger protection for the brain, especially the visual cortex that was important for the early amphibians, what happened is that an adjacent structure, the mesenchyma that was around it, was transformed into a bone by a direct ossification. So this is the reason we have intramembranous ossification for some bone versus endochondral ossification. Now, all the bones that are new, so the shoulder and the pelvic girdle and the skull, are intramembranous ossification. And that is of importance because some of the conditions that affect the long bones will not affect those bones. In particular, you know that achondroplasia, they have this big square head, so they don't have a problem with the head being too small. They have a problem with the long bone being too small, but the head is normal. However, the foramen magnum, which is part of the occipital bone, the foramen magnum did exist in the shark, and so they have stenosis of the foramen magnum. Another association is that babies that have problem with the clavicle may also have problem with the skull itself. So these are babies that have cladocranial skeletal dysplasia. So there are interesting variations between the formation of those different bones. Now, when the clavicles are hypoplastic, it is usually the medial portion that is absent, and only the lateral portion is present. Here we have the normal clavicles in the normal fetus, and here we have a very severely hypoplastic clavicle in a baby with trisomy 18, and another one here with another baby with trisomy 18, in which about 2/3 of the clavicle is actually missing. There are few syndromes that have hypoplasia of the clavicle: Fringe, cladocranial dysplasia, pycnodyslostosis, trisomy 18, 13, Halterman, and so on and so forth. Now, babies that have the cladocranial dysplasia also have a very striking finding. If you look at the skull, at the level of the metopic suture, instead of having the metopic suture in front of the two lateral projection of the frontal bone, the metopic suture is actually posterior, and there is some frontal bossing that is to the side of the metopic suture, not to the middle of the metopic suture. Very typical of cladocranial dysplasia. And by the way, those babies also have a delayed fusion of the mandible, another finding from that condition. Let's go to the ribs now, and some babies have 11 pairs of thoracic ribs. You know that the segmentation is not set in stone, and there's quite a few variation in the segmentation of the spinal the vertebra. And here we have babies that have 11 pairs of ribs. Now, 11 pairs of ribs is well associated with certain conditions like trisomy 21, but it was hard to detect at first. The only way in the old days was to make a sagittal section in which all the ribs could be counted one after the other. This became easier when cine loop came around, because then we could go make a pass and then count back how many ribs were present. But of course now this has been simplified dramatically with the advent of 3D reconstruction. Here we can count very simply how many ribs are present in the rib cage of this baby. And there's quite a few syndromes that have 11 pairs of ribs. Of course, trisomy 21 and 18 are two of the important ones. Camptomilic dysplasia and several other cleidocranial dysplasia is also here. And asphyxiating thoracic dystrophy, the Jeune syndrome, is also here. Now, instead of having 11 pairs, you can also have an extra pair. This is 13 pairs of rib, and this is associated with a different set of anomaly. You can also have short ribs, and in short ribs, the rib cage, instead of a normal size, is narrow, and that narrowing is what caused the lethal skeletal dysplasia for being lethal. They're not lethal because of their bones being too short. They're lethal because the rib cage is too short to allow the proper development of the lungs, and that causes lung insufficiency when the baby is born. So that's a very important criteria to recognize. Now, that is visible in several ways. You can either use tables with age-dependent circumferences, or you can use a ratio, and I think that's the easiest way to do. You do a chest to abdomen ratio, and visually you can see that the chest is about 80% to 100% of the size of the abdomen. If you look in comparison to that with a baby that has thoracic dysplasia, as in this case, you see that the chest is much smaller in thoracic dysplasia than the abdomen, and so now we have a ratio about 40 to 60%. That's an important criteria to recognize a baby has chest hypoplasia. Now, sometimes the chest is so narrow that not only the lungs are compressed, but the esophagus is also compressed, and when the esophagus is compressed, the baby can't swallow properly, and polyhydramnios result. And here we have two fetuses, one with thoracic dysplasia type 1 and one with thoracic dysplasia type 2, and you see that both have very narrow chests here and there, and they have polyhydramnios at the same time. An abnormal short spine results from vertebral body that are too small, too narrow, or missing, and this is part of Draco-Lewin syndrome or Craniosynostosis. And in that case, what we see is that the ribs, instead of having a paddle, a comb-shaped distribution, have a fan-shaped distribution with the apex of the ribs pointing to the same point, while the distal portion of the ribs is pointing far apart. Let's go a little bit over the embryology of the vertebra. The vertebra has an upper and a lower plateau, and each one contains 4 ossification centers, and there are also 2 ossification centers in the posterior lamina. Now, these 4 ossification centers on top and the bottom are rapidly going to fuse into 2 and 2, and then into 1 and 1 on top and in the bottom, until those upper and lower ossification centers do fuse together into one single ossification center. At that time is what we see with the prenatal ultrasound around the second trimester. We see those 3 ossification centers, which represent the posterior lamina and the vertebral body. Now, as we know now that the central ossification center is made of several subunits, it is easy to understand the anomalies of segmentation of the spine. For instance, we could have a failure of the anterior and posterior ossification center to fuse together. That would be a coronal cleft. Or we could have a failure of the superior and inferior ossification center. That would be an axial cleft. Or we could have a lateral division in which the right side and the left side fail to fuse together, and then we would have what is called a butterfly vertebra. And each one is associated with its own set of anomaly. And there's a lot of genetics that is involved into the division of the vertebra. Another condition that may happen is that instead of having the normal alignment of a vertebral body, a disc, another vertebral body, a disc, one of the discs may be missing, and therefore two vertebrae may be fused together into one large block vertebra, and that occurs in a certain number of conditions also. Now, one of those that is quite common is the hemivertebra. If we schematize the ossification with the vertebral body and posterior lamina over here, this is the normal ossification center, resulting into this normal schematic of vertebral bodies and ribs to the side. Now, if a part of the vertebra is not formed, for instance, one side here is not formed, this is going to result into a scoliosis. Or if the frontal, the dorsal, or the ventral aspect of the vertebra doesn't form, then we'll either get kyphosis or lordosis of the spine, and this is going to present an angle in the spine. Of course, if the neural arch doesn't fuse, then we have spina bifida. Now, these are examples of babies that have hemivertebra, and you can see the nice alignment of the vertebral body here, and this forms a curve at the apex of which we have a broad vertebra. This vertebra here is larger than the adjacent one, and this is a block hemivertebra in which one hemivertebra has fused with an adjacent normal vertebra. This is another example here where the fusion is partial. This is another example here with unfused segment, and another one here with an unfused segment, and finally another one over here. This is the baby in the image 2 years later, and on clinical exam it is very hard to recognize that this little girl has a scoliosis. And that is an important thing to tell the parents and the pediatrician, because the prognosis for the repair of those baby is better when the treatment is applied early. So that is something that should be mentioned during the ultrasound that we perform. Now, of course, if you talk about hemivertebra, the knee-jerk reaction is to look at the heart, because remember, the VACTERL syndrome, V is for vertebra, but C in the VACTERL association is the cardiac anomaly. So any baby that has a spinal anomaly like this one should be checked for a cardiac anomaly. Let's move now into the appendicular skeleton, and we're going to look at a great number of terminology and definition. And no one likes to learn about definition and terminology, but it is important because that baby that you're scanning at some point, if it has a problem, will go in the hand of someone else, and that someone else will be a dysmorphologist, a geneticist, and telling them the baby is a funny looking kid is probably insufficient. You may want to speak the same language as they speak. So let's go over some definition. If the root of the arm or the leg is too short, we talk about Rhizomelia. Rhizo means root in Greek. And there is a series of conditions associated with Rhizomelia, such as Thoracic dysplasia, atelogenesis, dystrophy dysplasia, and of course the proximal femoral deficiency syndrome. If instead of the root we have the middle portion of the arm that is affected, we talk about Mesomelia, meso meaning middle portion in Greek. And the cover stem association and mesomelic dysplasia are two examples of mesomelia. Finally, if the distal portion of the limb has a problem, the hand or the foot, then we talk about acromelia, and condylodermal dysplasia is one of those examples. Very often, actually, the baby will have a shortening of all three segments, and then we talk about Micromelia, and there is a list of conditions that are associated with Micromelia. Now, Micromelia doesn't mean that the limbs are absent, they just mean that it's short. And for instance, here this is a 23-week fetus whose humerus is about 17 weeks. Now, 6 weeks of difference at 23 weeks, that is a very significant difference. So don't expect the limbs to be absent. This is just shortened. They would probably look rather normal when you look at them without measuring them, but once you start measuring, you see that they fit way below in the table and the nomograms. A hip dislocation is another thing we can see when we look at the limbs, and the hip dislocation prenatally are always posterior hip dislocation. I don't want to say that this is a good screening tool. The postnatal screening is a lot better than the prenatal screening, but from time to time you may look at hip dislocation also. I've looked at here at the pelvis seen from a head to bottom approach, and I've made the iliac wing transparent so you can see the position of the hips at this level. Now if you trace a line between the femoral head at this level, that line is going to go either through the bladder or in front of the sacrum. So if you have posterior hip dislocation, expect that this line is going to go behind the bladder or is going to go through the sacrum. And this is what you see over here. This is the femoral head, this is the bladder, and this is the second femoral head. And you see that this line is way past the bladder in this fetus. And there's a great number of conditions that are associated with hip dislocation. And let's go now into some limb anomalies, and often it is difficult to be precise in what the anomaly is. So instead of saying something is wrong, you can say the baby has ectromelia. Ectromelia is a very vague term that says that there's a congenital hypoplasia or aplasia of one or more limbs. So this is as broad a term as you can possibly describe. So this fetus here, for instance, with all these different malformations, would have ectromelia. Meromelia means that there is a partial absence of a free limb, excluding the pelvic girdle. For instance, this little girl here has a normal shoulder blade. You can see the humerus, the elbow, but look at the ulna and radius. There is a distal transverse amputation. This is not a amniotic band syndrome. This is a different type of condition, and she has a net spontaneous amputation at this level. Phocomelia is a more severe condition in which there is a development of the limbs such that the hand or the feet appears to be attached to the body, just like the flipper of a seal, that is phoco in Greek. And the worst form of that is Amelia, in which the baby has neither arms nor legs. This is a baby that has tetraamelia, and you see the absence of arms and legs, something that is rather easy to recognize, but actually I have reviewed lawsuit in which the finding had been missed. A hemimelia means that there is a partial absence of part of an extremity. For instance, here we're missing the humerus. But one of the most common form of hemimelia is the intercalary hemimelia. In intercalary hemimelia, what is absent is one of a pair of bone. Remember that all the limbs, this was part of all the evolution theory, and this one of the finding of Darwin was that all the limbs are made of one bone, two bone, a bunch of little bones, and then digits. Well, this is the absence of the second bone of the series. So here we are missing, for instance, the radius of the ulna. And one of the forms of that is the radial radioplasia, in which the radius and the thumb are missing, and that always leads to a clubbed hand. So if you find a clubbed hand, look for the radius. It probably is going to be missing, and this is the radial radioplasia, one of the forms of intercalary hemimelia. You can also have bowed and bent bone, and this is a division that is probably a bit specious because there's a great deal of overlap between the appearance of the two. But sometimes you will clearly see a bowed bone, and that, remember, is associated with the boomerang dysplasia, the camptomelia dysplasia, diastrophic dysplasia, and several others, while an angled bone is more likely to represent osteogenesis imperfecta or the kyphomelia dysplasia. Let's go to hand and foot anatomy, and here there are multiple tables I'm going to skip because we don't have much time, and all this is in the literature. I just want to make you aware that those distinctions exist so that you're going to be more precise when you have a case in your practice. Polydactyly is the presence of an extra finger or an extra toe. As you can see, extra finger are about 3 times less common than extra toes. but sometimes they both associate together. This baby here has an extra finger here and an extra toe over there in both feet. They rarely lack on the image that I have drawn here. You'll see that is very uncommon. Much more commonly, it will be just a little nub of finger. There are all sorts of recurrence risk, and you can have a autosomal dominant form. You can have multiple forms of transmission, and it may vary from an entire extra digit, which is very rare, to a rudimentary skin tag, which is much more common. And then that skin tag on ultrasound may not be quite clearly a finger. For instance, here, if you look at this thumb, it's this wrist, it is not clear that this is an extra finger. You have to scan carefully at this level, and this is this same baby. Now, polydactyly have been divided roughly in two types. If you draw the axis of the limb alongside the limb here, the pre-axial polydactyly are polydactyly on the side of the thumb or on the side of the big toe, while the post-axial polydactyly are on the side of the fifth digit or the little toe. So that allows to recognize different entities. For instance, here we would have a pre-axial polydactyly of the thumb, while this would represent a post-axial polydactyly of the fifth digit. Now, pre-axial polydactyly is less common than the post-axial polydactyly, and the example that I've shown you up to now were all post-axial polydactyly. The pre-axial polydactyly rate are similar for both African American and Caucasian, but the post-axial polydactyly is 10 times more common in African American than in Caucasian. And so quite often you will have a mom that asks you whether the baby that she is carrying has an extra finger, and all of a sudden you didn't pay attention very well. You go back to look at the answer and say, oh yes, it does. And the previous child already had that. Now, this is the classification. The type 1 is thumb polydactyly or pre-axial polydactyly type 1. This is 3 to 4 times more frequent in Native American than in Caucasian or African American. And remember that Native American probably descend from population that came from Asia, and in particular in India, the Hindu population has a great number of babies that have pre-axial polydactyly type 1, the thumb polydactyly, and in Hindu religion, this is actually considered to be a good sign, and those baby, the thumb is preserved. The type 2 is another one that is important. Here we have a triphalangeal thumb. This is what happens in Holt-Oram syndrome. In the type 3, we have polydactyly of an index, and type 4, polysyndactyly of the first finger, and syndactyly of the third and fourth finger. Not a very common. So let me show you here an example of polydactyly. You see the fingers here. There's an extra finger on the side, and you'll see when the baby moves that this little extra finger is barely attached to the hand. There it is. It looks like some little numb of skin that is attached very weakly, and usually what happens is when the baby is delivered, the nurse on labor and delivery places a little thread and strangle the finger, and by the time you come and take picture, the baby has already lost the extra digit. So this is a common anomaly that is very easily tolerated. Here's a baby that has an extra toe, another one that has an extra finger. This is the Ellis van Creveld syndrome with a post-axial polydactyly. This is a post-axial polydactyly type B, the pedunculate post-minimi. This is by far the most common, you see over here. Here are other examples of the type B, little extra digit. And of course, this is rather easy to see with 3D than with 2D. Here's polydactyly of the thumb. We have a duplicated thumb at this level. The triphalangeal thumb, here we have a long finger that looks like a regular digit. This is the thumb that has been elongated, and this is part of Holt-Oram syndrome and part of several other conditions here. Another problem you can have is again, ectro means a problem with no specification. You can have hectrodactyly that has multiple forms of transmission. And here we see one of those hands. This is a case in which you have the lobster claw deformity with the hand being widely open. If the deformity extends into the metacarpals or the metatarsal, then we talk about the split hand, split foot syndrome. And there are several conditions that have been diagnosed prenatally. This is an example of that, with a hand that has almost a chameleon type of hand. And this is several adults with the same type of disorder. What is important in these babies is to recognize whether the thumb can be opposed to the rest of the fingers. If the thumb can be opposed, then the hand is prehensible and the outcome is much better than if some surgery has to be done to repair the prehensibility of the hand. A trident hand is a hand that has a gap between the third and the fourth finger, and that is quite characteristic of achondroplasia. And here you can see the gap between the third and the fourth finger. Now, many babies can do that. What is important is to make sure that this persists during the whole exam and is not just a very temporary finding. A hitchhiker thumb, this is a thumb that is maintained at 90 degrees to the hand, an uncomfortable position that baby should not be able to keep for more than a few seconds. Brachydactyly is another condition that has multiple variations. These are short fingers, and there are 173 syndromes, quite a few prenatal references prenatally. One other form of brachymesophalangia that is important is the brachymesophalangia of the fifth digit. Here, the phalanges is too small. Because of that, its articular surface here is abnormal, and that leads to clinodactyly, the position of the fifth digit phalange, the last phalange, that is abnormal and is bent in. That is quite typical of trisomy 21. So this is one of those that we look for prenatally. Here we have an example of clinodactyly. You can see that the fifth finger here is rotated towards the fourth finger. Syndactyly is another set of finger condition with multiple conditions reported in Wormian and multiple prenatal diagnoses. And it also has quite a large classification that I'm going to skip. One that I want to mention, however, is the mitten hand. The mitten hand is a form of syndactyly in which all the fingers have been fused together. And I thought for a long time that it was not possible to recognize soft tissue or cutaneous syndactyly, and only we could see the bony syndactyly. That's actually not true. If you can see here, we have a section in which you see that the skin is not indenting in between the finger. The skin is passing over. And remember that these are phalanges, these are non-metacarpal. The metacarpals are not ossified in the fetus, so we know that these are fingers. So I think the diagnosis of mitten hand is something that we can do, of course, with 3D, but also, this is the 3D version of it, but also with 2D. And this, of course, is one of the acrocephalopolysyndactyly. Apert syndrome is a good example of a mitten hand. A short fourth metacarpal, this is part of Turner syndrome. There's other conditions that have that. Camptodactyly or clinodactyly are two different conditions. In camptodactyly, the finger is bent along its normal flexion axis, and in clinodactyly, it is bent in a radial curvature, so it tends to touch the adjacent finger. And of course, there are differential diagnoses for each of these conditions. Clinodactyly is a bit more common than camptodactyly. This is an example of camptodactyly. You can see the finger here is bent. The other finger here have been amputated, but this is an artifact of the 3D. Pay attention only to the fifth finger. This is a common problem of doing 3Ds. You pay attention to an area, get a good picture of that area, and then forget to look at the acquisition of the rest of the image. This is clinodactyly, and you see the overlapping of the finger over here, and another little fetus whose fifth finger is clearly overlapping the forefinger, and the brother of that child also had the same finding. Oligodactyly means that a finger is missing, and here we have one missing finger, and there's lots of conditions. Of course, amyloid band syndrome is one of them. Akira is absence of a hand, and in this video clip you can see that the left hand was clearly identified during the exam, but as the sonographer looks into the heart and into the right arm, you see the right arm ends over here, and there's no hand at this arm. There are two clenched fists you really should know. One is the trisomy 18 with overlapping of the third digit by the second digit and the fourth digit by the fifth digit. This is the 3D ultrasound rendering, and this is the pathology specimen. This is extremely typical of trisomy 18. The other clenched fist is the one of triploidy, in which there is a cutaneous syndactyly of the third and fourth digit. A few foot anatomy, and we'll finish on that. You can either have a club or a dislocated foot. The dislocated foot, of course, has a much worse prognosis. You can have a vertical talus and calcaneus, which gives a rocker bottom foot. This is very typical of the trisomy 18. A increased space between the first and the second toe. This is called a sandal gap, and this is a marker for trisomy 21. Elevation of the first toe is also a marker for trisomy 21, and then you see the sole of the foot, but you don't see the big toe in the same plane. You have to move the transducer in order to acquire it. A short first toe is an anomaly associated with trisomy 18. And then absence of the foot is another similar condition to the Akira that we saw a few minutes ago. I hope that I have given you, in this brief review, some of the important findings associated with skeletal dysplasia, and I have rekindled your interest in making right terminology and right diagnosis in this topic. Thank you very much.